thank you for that, and thank you for inviting me. I have to confess, I'm not from NICE. I'm what they call, or what I was a co-opted member for this particular NICE quality standard. So I'm going to talk to you about the development of this particular NICE quality standard and the difference between standards and guidelines, because sometimes it can be a bit confusing. But my background is in health visiting. I am currently a senior lecturer at Anglia Ruskin University, teaching on the SCUFN programme. Now, SCUFN is a quick way of saying both health visiting and school nursing. So it's the specialist community public health nursing course, 0 to 19. So coming back to what the difference is between standards and guidelines. Development of standards always start with some sort of high quality guidance. This particular one we're talking about is based on the NICE guideline. Usually anything up to a set of 5 priority statements designed to drive measurable quality improvements. But they can be used for benchmarking, audit and demonstrating quality. But they do focus on actions that can be implemented at the local level. So the primary aim of standards is to drive improvement through the commissioning process. So I just want to take you back a little bit to the actual guideline that these standards were sat upon, published in 2012. And the guideline outlines the identification of risk of children under 5. And it covers the issues around social and emotional development, which is the bedrock of this conference. Home visiting, early education and childcare. It talks about actually whose health will benefit, and makes recommendations. So the recommendations around the guideline are both from the strategic commissioning and review point of view. It talks about identifying vulnerable children and assessing their needs. The antenatal and postnatal home visiting for vulnerable children and their families. The early education and childcare and the delivery of services. So I'm just trying to set the scene before I go into further detail. And the guideline also, the standard also incorporated these NICE guidelines as well as others. So we looked in detail at the pregnancy and complex social factors clinical guideline and the when to suspect child maltreatment guideline, but we also pulled in the promoting the health and well-being of looked after children from the Department of Education and Skills. And of course, the Public Health England document, the Healthy Child Programme. This particular one was looking at the rapid review. And you have to forgive me because I am a health visitor through and through. I am going to concentrate on looking at the Healthy Child Programme and how that fits into the standards. So for this particular guideline, this particular standard, there were only 2 standards. The standards are parents and carers of children under 5 have a discussion during each of the 5 key contacts. Okay, it's those 5 key contacts about factors that may impose a risk to their child's social and emotional well-being. And the second standard is to do with the speech and language skills. So these need assessing at their 2 to 2.5 integrated review. And we've heard a little bit about that this morning about the integration, because not all areas have progressed on to the integrated review. So just to bring it right back to basics, NHS England in 2014 hold this as the Healthy Child Programme, a prevention and early intervention public health programme that lies at the heart of the universal service for children and families. I just want to stress that universal service, and aims to support parents at this crucial stage of life, promote child development, improve child health outcomes, and ensure that families are at risk families at risk are identified at the earliest opportunity. So clearly, unless you have a universal service, you're never going to be able to target those who might be more vulnerable than others. So Viv Bennett has given me permission to show her photograph. And she was she is our chief nurse, but she was the first one to coin this phrase, the 4-5-6 model. So the 4-5-6 model of the 0 to 19 service, she's the professional lead for nurses and midwives working in public health and social care, and the principal advisor to the government on public health, nursing and midwifery. So coming back to health visiting, school nursing, specialists in public health nursing. So those of you who are perhaps not as old as I am, but if you think about the history of health visiting and school nursing, we were very much grounded in public health. And it wasn't until 1974 that the health visiting service was incorporated into the National Health Service. And then most recently, we're now back into the public health arena of local authority. So we're just coming back to our roots, really. But this is her model. Now, I appreciate this is rather busy. I just wanted to show you the fact that the safeguarding, you can't really see it, we will go on to the next slide with more clarity in a minute, but the overarching theme is the safeguarding, but the 4-5-6 model goes from the health visiting service and the school nursing and the commissioning of the joined up working together model there. But to be more clear, this is just the health visiting model of, it's not much clearer, is it? The 4-5-6 model of the health visiting service, so that universal service. Just very briefly, I know you can't see it, but the four relate to the 4 levels of service. So it says your community, so working with local authorities, in local authorities, knowing your community, knowing your families, knowing where their needs can be best served. The universal element of the service provision is the 5 mandated visits. The Universal Plus relates to anything other than not universal within the health visiting team. So it can be child development, child behavioural issues, breastfeeding support, domestic violence support, postnatal depression, those sorts of public health issues held within the health visiting team. And then the Universal Partnership Plus relates to working with other services such as early years, social care, and the like. So the 5 of the 4-5-6 model relates to the universal health reviews starting in the antenatal period. So health visitors need to work very closely with their midwifery colleagues to just purely know who's pregnant within their area, but to work together to how best to support that family. And health visitors take a slightly less medical stance to supporting a family and talk very much more about the expectations of those parents. How do they expect new parenting to be? What do they understand by what new babies need? Health visitors are schooled in child development and fetal development, so very often a conversation happens in the antenatal period about hearing development. The fact that a fetus can hear in the 3rd trimester, so that if there is domestic violence going on, then that fetus can potentially be exposed to that. New baby review clearly looks at what it's like having a new baby in the house. Commonly around about 10 days that happens. And the 6 to 8 review primarily focuses on maternal mental health. So there are various screening tools throughout the country, but health visitors are looking at maternal mental health, because we know so much about the fact that if a mother is unavailable for her baby, then that baby needs one person to attach to, so it doesn't necessarily have to be the mother. And there's no reason why paternal mental health cannot be brought into that visit. And the 1 year and the 2.5 year integrated review looks at purely child development and looking at things like home safety. Alison was talking about hospital admissions and dental caries. All of those sorts of preventative measures can be incorporated into some of these mandated visits. And then the 6 refers to the 6 high impact areas, and I will go on to that on the next slide, because NICE do cover some of this evidence about effectiveness of the Healthy Child Programme. So again, just bringing it back into context about the health visiting provision, how it's now back in local authority. So the October 2015, local authorities took over full responsibility from NHS England for the commissioning of public health services for children up to the age of 5. So it's now up to local authorities to decide the specific roles health visitors play and how health visitors integrate with local authorities to improve and protect the health of children and to ensure that local families thrive. But clearly there needs to be joined up working, joined up commissioning with the 5 to 19 element of local authorities. And certainly in my university, we teach across the 0 to 19 age range. Local authorities have responsibility to promote and protect health, tackle causes of ill-health and reduce inequalities. So that's one of their strap lines, reducing inequalities. But you can't reduce inequalities until you know where those inequalities lie. So commissioning of high quality public health services for those the 0 to 5 age range as part of the Healthy Child Programme can help to achieve all of this. So just to reiterate, really, the fact that health visiting is a universal service. And because it is a universal service, it is accepted by parents. There's no stigma, knocking on a front door. Your neighbours are not going to have their curtains twitching because you're a health visitor. Might be different cases for different professions. So health visitors are trained to give support and advice to parents, promote positive parenting and emotional attachment and bonding. So positive parenting, just things like, he doesn't like me, he's crying because he doesn't like me. Those sorts of nuanced discussions can be very subtle, but can be ringing alarm bells for health visitors. Inequalities in access to services are reduced and potential safeguarding risks are identified due to this very nature of universalism. We are skilled at assessing child development and have a role in educating families on home safety, improve uptake of immunisations, and are instrumental in safeguarding children and vulnerable adults. So that assessing child development, putting that in context, when you're home visiting and you notice there's no stair gate and that child is 8 months, for example, and you know that, come next month, that child might well be toddling or at least crawling, those sorts of little pointers to decrease the risk of home accidents can be invaluable. And where I've got the vulnerable adults on that last point, this is the vulnerability of new parents. It could be domestic violence. It could be depression. Those sorts of issues. That all of these that impact on the child, because we do need to focus on the child and have the child at the centre of absolutely everything we do. So NICE recommendations for local authorities commissioning of the health visiting service include, as I say, these are factored around the 6 high impact areas: preparing people for parenthood and supporting families in the early weeks after birth. New parents, 99.999% of parents, don't ask me a reference for that, but really want to do the very best for their children. But sometimes they're not able to do their very best for their own issues, and sometimes they don't know. Sometimes their influences are from elsewhere, and health visitors are a trusted source of advice. Promotion and support in breastfeeding. And in a previous life, I was an infant feeding lead, so you're going to have to forgive me the last couple of slides, which are going to be focusing on breastfeeding and looking at the cost implications of support or cost implications of not supporting breastfeeding. Maintaining a healthy weight amongst families, because of course, as we know, childhood obesity is a huge public health issue and growing in more ways than one. So improving diet and increasing physical exercise, reducing unnecessary hospital admissions. What I wanted to also say about health visiting is that not a lot of people know, but health visitors all are independent prescribers. So they're trained in recognising childhood illnesses and are able to prescribe medicines from a limited formulary. So having some knowledge of spots, for example, can prevent children going into A&E, for example. Supporting maternal mental well-being, which is the 6 to 8 week visit. There are very many screening tools around. I mean, I was personally schooled in the Edinburgh Postnatal Depression School, which really looks at both depression and anxiety in one neat tool, and a lot of research papers base their research around using that tool. But there are very many other screening tools out there at the moment. But we know that actually a fair number of women do suffer both antenatal depression and postnatal depression. And if the health visitor is schooled in really good communication and able to get through to that mum needs to be able to trust her, obviously, but having a universal service so that each mum in their social networking groups know that actually the health visitor is not there to judge, the health visitor is not there to take a child away, which is sometimes a fear. The health visitor is there to support her in her upbringing of her child. There isn't quite such a robust evidence base about paternal mental well-being, but there's no reason why there can't be a screening used with fathers who, increasingly are at home bringing up children. And if you think of the impact on the child, the evidence suggests that if you've got a mother who's depressed, the fathers have a 50% increased risk of being depressed themselves. So if you've got 2 adults who are depressed, the impact on that child can be substantial. And then the 6th high impact area is the improving school readiness, the health and well-being at the age of 2. So, costs and savings. Effective use of health visitors to improve the health and well-being in the under 5s can lead to cost savings. There is pounds, shillings and pence, that's showing my age, pounds and pence money in some of these interventions. I'm not going to steal the thunder of Alicia or Dr. Thompson. There are the cost savings in the parents' early education programs, but I just want to move on to breastfeeding. And as we've heard earlier this morning, breastfeeding is so much more than nutrition. The old slogan of breast is best needs to be abandoned, and I know it's not so catchy, but breastfeeding needs to be looked on as normal. It's normal to feed a human infant with human milk, top and bottom. And these are 2012 statistics that UNICEF have presented. So in their document, Preventing Disease and Saving Resources, the potential contribution of increasing breastfeeding rates in the UK, the 2012 statistics suggested that 17 million in treatment costs could be saved if rates increased, so that 45% of women exclusively breastfed at 4 months and 75% of babies who were breastfed at discharge from hospital. But you saw from Alison's slide earlier on that we have a long, long way to go. If we're looking at WHO recommendations of exclusive breastfeeding till at least 26 weeks, that's 1% of our population. We have a long, long way to go. But NICE do recommend the implementation and evaluation training for health visiting teams as part of the UNICEF Baby Friendly Initiative Community Award. I'm sure a lot of you are familiar with these standards. UNICEF have standards for neonatal staff, midwifery staff, health visiting staff, and children's centre staff. So it's one package that has been favourably costed to make the difference to our families in all of our areas. And the other research study I wanted to just bring your attention to is a study that was based in Dublin by Reynolds, and they looked at mental health well-being and childhood obesity, but they found that breastfeeding in infancy is associated with a 26% reduction in the risk of abnormal strengths and difficulties questionnaire scores, and independent of child obesity is a predictor of child mental well-being. So we're bringing it right back to what we're talking about today, that in 9-year-olds they were able to show that children who were breastfed had better scores on their child mental well-being scores. And I just wanted to finish on a 2-minute video from UNICEF. I've been given permission to show this video, which sums up the collective responsibility of us all. References at the end of the slides. Thank you very much.